So let's talk about the placenta accreta, which is a tricky subject because we know all the morbidity that can provide from this pathology. So first of all, I would like to propose a little clinical case. You can see on this slide that there is some different sorts of lacunae, as you can see here, and just one case is about placenta accreta. So I let you choose the slide, the correct slide, and after the talk, we'll review this question together. When we see the development of the placenta, we can see that there is a tricky borderline between the simple adherent placenta, the accreta placenta, which is partially inside the myometrium, the increta, which is quasi-completed, and the percreta, which is all over the uterus and throughout the bladder, for example. You can see the other forms of the placenta accreta, which is a spectrum between the superficial form and the deep form. And which is very important is the vascularization of this placenta accreta sorts. So the borderline is very tricky, and we know that adherent placenta will provide some blooding delivery, and it will be worse and worse due to the deepest form on the accreta. So here, recently, and especially the English team, decided to talk about a spectrum disorder and not placenta accreta, which reflects all these thoughts about the continuum between superficial adhesion, and it is adherent or non-invasive or superficial placenta accreta. And the most severe form will be increta and percreta. But which is important to know is abnormal adherence and invasion may coexist in the same placental bed. So here again, the diagram of all those different forms. So first of all, we have to suspect placenta accreta when we have specific conditions. The placental position, and when it is previa, we have to question about that. Is there a placenta accreta or not? The caesarean section's history, and more you will have caesarean section, and more you will have risk of placenta accreta. The oldest woman, maternal age superior to 35 years, and previous history of accreta. So all these conditions have to be questioned about placenta accreta. And you can see on this diagram that there is a parallels between the number of caesarean sections and the occurrence of placenta accreta. First point is that we have to suspect, and we can suspect abnormal insertions since the first trimester, and specifically when the invasion of the placenta is near to the cervix and near to the previous caesarean scar. More recently, FIGO consensus decided about to emphasize main points will be considered into the diagnosis of placenta accreta. And for the diagnosis, we have two main imaging. We have the ultrasound, first of all. It is to pick up the placenta. And in second line will be MRI to confirm or to try to precise the depth of the placenta invasion. In ultrasound, there are 4 main signs concerning the diagnosis of placenta accreta. And the first of all, and which is the most important, is the lacunae. When you have this specific lacunae, which are called bizarre, and the bizarre is due to the irregular edges, no hyperechoic halo, you have a border here, but no hyperechoic border. They are located to the basal plate, and they are numerous and close together with a specific vascularization. And we'll see that it is typical of swirling flow. So it is this aspect of lacunae, which are very numerous and close to each to one. And when you put Doppler, you have this swirling particular flow. And when we rebuild the images, you can have this cartography, this map of important vessels. When we perform histology, the particularity of placenta accreta is that you have invasion of fetal vessels into the myometrium. And into the myometrium, you have specific arteries with low resistance, which is quite different than the main vascularization of the mother. So here are the specific items to say and to confirm the placenta accreta in histology. So when you put the Doppler, look at all those numerous vessels very close to the interface between the myometrium and the placenta, and which could be very interesting is to measure the velocity into the venous lakes here. And you can see that the velocity are very high, around 100 centimeters per. So bear in mind that we have this hypervelocity inside those lacunae. Here you have the difference of a normal vascularization, and here the important velocity. So placental lacunae is a very performant, accurate sign, as you can see here, with a sensitivity near to 80%. So when you have this typical lacunae, we have to suspect placenta accreta. The second side, very important, is the loss of the clear zone. And here on the left, you have normal patterns of placenta, low inserted, and you see that even it is very thin, you have this hypoechoic plane, as you can see here. When you lose this clear zone, and you have the example on the right here, it means that probably you have an abnormal invasion. And when you put Doppler, you have this specific vascularization here. So the loss of the clear zone is very important to pick up, and you can see that they develop in front the lacunae, as you can see here. And the FIGO consensus emphasized a very important sensitivity, around 70%. So these two first signs are very important. In this clear zone, you put Doppler, and if you have placenta accreta, you will be able to demonstrate this typical double rail image, as you can see here, which represents the specific vascularity of the bladder serosa here, when you have placenta accreta. It doesn't mean that you have a percreta form, but it means that you have a particular hypervascularization of the layers of the bladder. So here again, we have to bear in mind this typical pattern of vascularization in this loss of clear zone. Here you have example of this particular vascularization in contrast with the normal aspect on the right side, as you can see here. The fourth sign in ultrasound is the placental bulging. It means that the placenta stayed low inserted and did not develop with harmony during the gestation. So you have an aspect of a mass in this placenta, and the borders are bulging, as you can see here. So it is important to know the difference of a low-lying placenta. Here on the right you have normal pattern. You can see that the morphology is quite regular. You have here echogenicity harmonious here, and here you have this bulging aspect with all those lacunae. So the fourth signs, and specifically when they are combined together, as very accurate to suspect the placenta. And this model will be studied and emphasized recently. And you can see that when you have these four signs, these four biomarkers, means loss of clear zone, abnormal placenta lacunae, placenta bulge, bladder wall interruption, you are very close to the diagnosis, and you can see that the corrected index is near to 1. So these four biomarkers are probably the most important signs that we have to keep in mind. And the second imaging, and we'll perform it in the second slide. And I know that it's not so easy to have access to MRI, but when it is possible, it could be very useful. First of this argument is due to the very good contrast between the placenta here and the myometrium. And you know that we have ultra-fast sequences now, which are very easy to perform, and we don't have the burden of movements of the fetus. So we have a very accurate images, as you can see here. So we can follow the border between the placenta and the myometrium, and the signs and the semiology of MRI are this one. We have 5 main signs that we have to look for to do diagnosis of placenta accreta. First is the interruption of the placenta, and you can see here that when you follow the line between the myometrium and the placenta, there is an interruption here with the exophytic placenta through the myometrium, which means that it's probably a placenta accreta. But you have to compare this image with 2 other plans, the sagittal one and the coronal one, to be sure that it's not a partial volume. So you have to see all the examination. When you have focal interruption of the retroplacental border, you have sometimes just a thinning of the layer of the myometrium, as you can see here, and sometimes it is very difficult to see the interruption. But what we have to know is when you have this very thin myometrium, it's probably something that will argue the fact that there will be blooding delivery. The other aspect is the bulging aspect of the uterus, as we talked about previously with ultrasound. And when you have this aspect of mass, of important mass with irregular border, you have to suspect placenta accreta. And you can see that the uterine bulging is very accurate, near 80% in the diagnosis. The placental tissue heterogeneity, which reflects the lacunae in ultrasound, is a good thing to talk about placenta accreta. Here on the left, you are low-lying placenta, and you can see that the signal is quite homogeneous, and the morphology is quite similar into the different parts of the placenta. When you have an invasive placenta, you can see that the tissue is very heterogeneous in T2, you can see here, with a lot of lacunae and dark bands, as you can see here. It's another important thing to say to pick up placenta accreta. The dark bands, here you have examples. Hyposignal T2, which are dark, like you can see here, probably reflect the fibrosis into the placenta. And when you have these dark bands, you quite be sure that it is probably a placenta accreta. A recent study talked about the thinning of the myometrium and talk about the number of dark bands. And more you will have a thin myometrium in front of the placenta and more you will have dark bands, it will be more risky and more correlated to the risk of hemorrhagic delivery. As you can see on these curves, when you have numerous dark bands and when you have a very thin myometrium, the blood loss will be superior to 2 liters. So it is some reliable signs concerning the morbidity during the delivery. And the last sign will be this particular aspect of the bladder, which will be triangular like this, with a 10 at the percreta sign, because all the placenta invade the myometrium and go through the serosa of the bladder, as you can see here with this mass invading the serosa and all the layer of the bladder, as you can see here. So it is important to keep a full bladder when you perform ultrasound or MRI, because you will have a more important contrast between the placenta tissue and the bladder. Here you have this typical aspect of tenting of the bladder, as you can see here. So just remind this, and you can do it with the ultrasound, and which is very helpful in ultrasound is that we have the Doppler. So you can have this particular aspect of the bladder, and just in front, this very important vascularization inside all the placenta bed. The question is probably, is it useful or not to use contrast during MRI? And we know that it's not so safe to do MRI with contrast in pregnant women. But when the benefit is superior to the risk, we can question about that. And we did the comparison between the placenta with gadolinium, with injection, and we tried to compare the accuracy of both imaging. And you can see on this diagram that it's more helpful for non-experienced operators. I mean that for junior radiologists, it's probably useful due the good contrast and the better contrast between the placenta and the myometrium with injection of gadolinium. Another question that we try to study in Necker was if there was a specific vascularization in the accreta area compared to the other parts of the placenta. So we tried to compare the enhancement curves with injection of gadolinium. And you can see here in non-placenta accreta, but previa, low-lying placenta, that the vascularization is quite similar inside all the different areas into this placenta. In contrary, you can see that when you have placenta accreta, you have very important hypervascularization is in accreta area compared to other part of the placenta, which are nor-accreta. So maybe it will be the clue or one of the clue of the diagnosis. But for that, we try to assess other techniques as here ASL, which means that you can study the vascularization without using contrast injection. So we try to study this possibility. So let's talk about the first slides. In your opinion, which is the lacunae which are due to placenta accreta? The A, the B, or the C? The B. Okay, well done. It was exactly, and you know that you are strong, so it was the good diagnosis. Here you have this particular and bizarre lacunae near to the border between the myometrium and with no hyperechoic borders. So to conclude, you can see that there is a complementarity between ultrasound and MRI. Placenta accreta had these vascular particularities, and we have to study, and probably the diagnosis will rely on this particular vascularity. It is very important to have this notion of specific lacuna interface. And when you study the placenta, just let's see the whole aspect of the placenta with this typical abnormal morphology of the whole placenta. So thank you very much for your attention.
Thank you, Dr. Billy Sher from Necker, for her very interesting talk and full of impressive images on sonography and MRI imaging. Thank you again.